Welcome to episode 162 of Real Health Radio. You can find the links talked about as part of this episode at the show notes, which is www.7, so the word all spelled out, SEVEN health.com/162. A couple of weeks ago, I mentioned that I'd reopened my practice to new clients. I do this twice a year. Client work is the core of my business and the thing I actually enjoy the most. And after working with the clients for the last decade, I feel confident in saying I'm very good at what I do. And when I reflect on the clients I've worked with over the last couple of years, there are a handful of areas that come up the most. So one of the biggest is helping women get their period back. So recovery from hypothalamic amenorrhea or HA. And this is often a result of undereating and overexercising and is almost always coupled with body dissatisfaction and a fear of weight gain. So the work with these clients, as with really all clients, is a mix of understanding physiology and how to support the body, but also being compassionate and understanding psychology and uncovering the whys behind these clients' behavior and figuring out how to change this. I've even had clients regain their periods after 20 years being absent after being told it would never happen. I also work to help clients who are disordered eaters or have been previously diagnosed with an eating disorder. And with these clients, there are symptoms that are commonly occurring. So water retention, poor digestion, always cold, peeing all the time, especially in the nighttime, no periods or bad PMS symptoms, low energy, poor sleep, low thyroid. And they also have common sort of mental emotional symptoms. So a compulsion to exercise, fear of certain foods, anxiety, low mood or depression, poor body image, fear of weight gain. And with these clients, it's using that same mix of understanding science and compassion to help them recover. And I know that full recovery is possible. And I've had many clients who've had multiple stays at inpatient facilities where nothing worked for them, but they've now been able to get to a place where they are fully recovered. The final area is helping clients transition out of dieting and learning how to listen to their body. So they've had years or decades of dieting and nothing's worked. They know it's a failed endeavor, but they just don't know how to do anything else. How do they listen to their body? What should they eat? They're confused. How do they deal with the weight gain? And with this work, it's often a combination of intuitive eating, a non-diet approach, my nutrition understanding, and being able to guide clients towards listening to their body that helps them be able to put an end to dieting habits and truly know how to nourish their body and to look after it. And these are the kinds of clients that make up the bulk of my practice. And I'm very good at helping them get to a place with their food and their body and even their life that they think is impossible. So if any of these scenarios sound like you and you'd like help, then please get in contact. You can head over to www.7, so the word all spelled out, SEVEN health.com/help, so HELP. And there you can read about how I work with clients and you can apply for a free initial chat. And at the time of recording this intro, I have just 3 spots left. And I would imagine that by the end of next week, all of those will be booked up by the end of next week at the latest. And after this, I won't be taking on new clients again until the start of 2020. So if you're interested, then please get in contact. The address again is www.7-health.com/help. And I'll also include that link in the show notes.
Welcome to Real Health Radio. Health advice that's more than just about how you look. And here's your host, Chris Sandel.
Hey everyone, welcome back to another episode of Real Health Radio. I want to say thanks to everyone on their kind feedback about the new website. I've had a number of people get in contact to say how much they like it. I've also had some people reach out and tell me about issues they've noticed. This is hugely appreciated. So if you do notice something wrong, please drop me an email at info@7-health.com and I can pass it over to the developer to get it fixed. So this week on the podcast, it is another guest interview, and I'm speaking to Julie Duffy DIllon. So Julie is a registered dietitian, an eating disorder specialist, and a food behavior expert, partnering with people on their food peace journey. She helps people with PCOS promote health without diets through her online course found at PCOSandfoodpeace.com. And Julie produces and hosts the weekly podcast Love Food, and you can learn more about her at juliedillonrd.com. So I've been aware of Julie for a couple of years now. She's someone who has appeared on many podcast shows. She's kind of carved out a name for herself in the area of PCOS and is really a fantastic resource on this topic. And I'm actually happy that I'd waited to get her on the show, because with the new longer format, we were able to give the topic a fairly extensive exploration. And this show is not a substitute for her longer courses that she offers that would go into many, many hours, but it is a really great starting place. And we started the episode as usual talking about Julie's background and how she finds herself doing this work. And interestingly, unlike most guests, she doesn't have her own story of dieting or disordered eating. She kind of managed to bypass all this. We then spend the rest of the episode really singularly focused on PCOS. So we chat about what are the symptoms and how is it diagnosed. We talk about the particulars of the diagnostic criteria and why it can be somewhat ambiguous and how this can lead to misdiagnosis. We talk about the different types of PCOS. And we then go through various dietary and lifestyle recommendations, and we look at what is myth and what is actually true and actually helpful. And I really enjoyed this conversation. I work a lot with women who suffer with hypothalamic amenorrhea, so when a woman is not getting their period. And then Julie obviously works a lot with PCOS. So it was nice to be able to chat about what we've noticed in our respective client populations and where there are similarities or where there are differences. There are a couple of times when Julie is speaking that you can hear a lawnmower in the background, but that's just podcasting for you. But that is enough of an intro. Here's my conversation with Julie Duffy DIllon. Hey, Julie, thanks for joining me on the show today.
Thanks for having me on, Chris. I'm excited to chat about PCOS.
Yeah, definitely. So yeah, that is really what I want to chat with you all about, like all things PCOS. And you are the go-to authority when it comes to PCOS, especially kind of dealing with it while focusing not on weight loss. And PCOS stands for polycystic ovary syndrome, in case people haven't heard the acronym before. And this isn't a topic I've done an in-depth podcast on before. So I've had guests on and mentioned PCOS as part of their story, but really never got into the science of it. And so, yeah, I just want to spend this time focusing on that and really picking your brains about PCOS.
I'm excited to talk about it. It's like one of my favorite things. I could spend a good month just talking about PCOS, especially from a perspective of like, what about if you don't want to pursue weight loss?
Yep.
Yeah.
Definitely. And I don't think that's what's being talked about by the majority of people. So it will be, great to hear your take on it that way. And I guess to start with, like, do you want to give listeners a bit of background on yourself, a brief bio of sorts, like who you are, what you do, what training you've done, that sort of thing?
Sure. So I've been a registered dietitian in the U.S. for 20 years. And I started out as a pretty typical dietitian that helped people with the pursuit of weight loss. And I worked mostly with diabetes. I was a diabetes educator for the first, I think, 7 years as a dietitian. And while I was getting really into working with diabetes, especially with kids, I found that I don't know, I just couldn't help people lose weight. And I was like, what's wrong? I guess I'm not trained in how to do this. And I found so many people that I worked with were experiencing stress and depression, anxiety, and family dynamic stuff. So I decided I just needed to be better trained in counseling. So I pursued a master's in mental health counseling. And when I was done with that, I was like, all right, now I can help people lose weight. And then when I got this job, I was like, wait, this is still not working. What's going on? And so I dove into the research, and in that place. There was probably a good 6 months where I was head down, full of shame, just realizing, oh my gosh, I've been really torturing people with weight loss. And I had to really just sit in my own kind of bias that I had been, taught. And so from there, I decided I was not going to put people on diets anymore, and I was going to be using only health at every size informed approaches. And this was back in I think 2005, 2006. And it was right around in there where I remember working with my first client with PCOS. And I had worked with people with PCOS before, but never from a place of completely I'm not going to do any diets. And I can remember taking out my big nutrition textbook that the dietitians, I don't know if it's worldwide, but just in the US, we have this big dietitian book called it by Krauss. I don't remember the name of the book, but everyone, if you're a dietitian, you know the Krauss book. And it's this huge, 4-inch thick book that we all had to lug around.
Is it like the dietitian's equivalent of the DSM?
Yes, exactly. Except it's not a paperback.
Okay.
And it's 8 by 12 instead of, a smaller kind of book. But so I remember sitting with this first client as a HAES-informed dietitian with PCOS and pulling it off my bookshelf and looking through it while she's sitting in front of me to be I don't know what to do, And there was a little tiny paragraph on PCOS, and it basically was treat it like diabetes and help them lose weight. And I'm that whole diabetes thing, there was something different about PCOS. I couldn't put my finger on it yet, but since I had worked with diabetes, I'm what people are bringing in is just different. And even though people with diabetes or people with PCOS rather, can get diabetes, but still there was something different. But I'm I also know diets don't work, so why would they work for PCOS? So I seriously, for about 10 years, I just looked for people who are willing to train me to work with PCOS without focusing on weight. And one person in particular that was super helpful, she passed away in 2017. Her name's Monica Woolsey. She's someone that was willing to, she wasn't HAES informed in a sense. Well, she was informed of it, but she didn't always practice from that way. And she was also willing to not put weight on the table as we were discussing ways to treat PCOS, but she took me under her wing and taught me a lot of different strategies. And from there, I've just been putting things together. And honestly, since I don't experience PCOS, I appreciate there's a privilege of the information I've come by, because it's really just people I've been working with PCOS, what they've told me that it has worked and what hasn't. For the first few years, it was kind of throwing spaghetti on the wall and seeing what stuck, and so we've accumulated what has stuck and what has helped a lot of people, what has helped some people. And, we call this practice-based evidence because we don't have research that's not weight focused when it comes to PCOS. It's just really hard to come by. So using this practice-based evidence along with as much evidence as I can get in the research has been guiding my practice ever since. So I have a practice in Greensboro, North Carolina, and I also have a podcast called Love Food, where I help some people with PCOS, but it's really for anybody who has a complicated relationship with food. So that is the last 20 years what I've been doing. And hopefully anybody with PCOS or someone listening who maybe knows somebody with PCOS, I hope this conversation helps just to clarify a little bit about what's going on and things people can do without focusing on weight.
Yeah, definitely. And so I do want to dive into the PCOS piece, but I just want to find a bit more about you. So how did you end up becoming a dietitian? Were you always interested in science, and this is how it went from there, or is there some other way you got into it?
There was another way I got into it. So it's funny because after you've been a dietitian for 20 years, you don't have to I don't know, I realize nobody's going to take my license away anymore. So there's a certain story I used to tell people about how I became a dietitian. That I got interested in nutrition in high school. I was a cross-country runner, and I wanted to improve my time. So I started looking into nutrition, which I did. But that's not really why I wanted to be a dietitian. I really wanted to be either an artist or a therapist. And in order to go to the college I wanted to go to, my parents were like, Yeah, no, you can't major in those. And so I was like, okay, let me see, what am I going to major in? So I'm just like going through the catalog, because it was a big book back then. It wasn't online, and going through the catalog. And I just pointed to a random major, and I was like, I want to major in this. And it was dietetics. And they're like, okay, that's fine. And I liked science. So like when I read through the requirements, I'm like, ooh. So I basically am about a class shy of a minor in chemistry. I hope I like it. But what I found is that I was not the typical dietitian. I still am not, because I am more big picture. I am someone who is definitely more built as like a therapist instead of this detail oriented kind of person. And yet I struggled with that for a long time, but I find it to be my strength, because so much of our world is so focused in on these exact kind of numbers, but they're missing the parts of like health and life and relationships. And that's where I see where I can guide things. And so studying nutrition, it allowed me to do things with like connection and helping people process things, but it was just different than I really imagined. So that's the real story of how I became a dietitian. And seriously, I didn't start telling that story till like 10 years ago, because I was like, I need to have the story that you put on your application letter, Yeah. That's the real story.
Okay. And it sounds, the part about you saying you're sort of bigger picture, less detail orientated. I would very much put myself into that same category. And I would say that that's one of my strengths. When you said about sort of just going down the page, becoming a dietitian and how well it has worked out for you, I don't know, the thing that came to mind was like arranged marriages.
Yeah.
Where like we think in the West of like, okay, you have to find someone, you fall in love, and then it all works out really well. And then you have the arranged marriage, and maybe after 40 years, they're just as happy.
Right. Yeah. Yeah. It's kind of funny how it worked out, right?
Yeah. And in terms of like you and growing up and food, how much of an importance was that when you were a kid?
So what I appreciate about my experience with food is I've never been marginalized because of my body, with the exception of being a woman. But besides that, I'm a white woman, I'm cisgender, I'm straight and Christian. So there's like, I've walked this path that is super privileged. So I never was pressured to go on a diet. And I think that's why I never did. And so as I was learning about nutrition in high school, I kind of was like, diets didn't seem interesting to me. I kind of thought they were boring, but a lot of that was because of my lived experience. It was the privilege basically coming through. But as I started going through college and learning about diets, I definitely was like, oh, I'm rejecting this. This is not something that I think is associated with health. But yeah, for the most part, growing up, my relationship with food, I was raised to be an intuitive eater before, that phrase was around. Yep. And it was, it was like diets and food. It was kind of just like, I think we had some loose structure with food, and there wasn't really any big deal about it. And it's probably because there was enough food. My parents didn't have to worry about making sure there was enough food. And it just wasn't really like, I never was told don't eat too much. It was just kind of like, well, there were a few times where it's like, you have to eat all the Brussels sprouts. And that's like the one food I can't eat now because I'm made to eat Brussels sprouts. But besides that, it was a very, I guess the way of relating to food that to me that I feel like is, was providing safety, but also just neutral. It was considered a neutral or pleasurable thing. And that's about it.
Well, okay. I think there is some more overlap between me and you, because it sounds like, I had a very normal experience with food. My parents never dieted. I can't remember any kind of dieting scars or food scars from growing up. And I know I'm an anomaly like that because that's just not most people's experiences.
Especially people who do the work that we do.
Correct.
And I definitely lack insight because I don't have experience with the struggle. And the older I get, the more I can connect with it just because I'm 44 years old and going through the aging process. And so I'm like, okay, I can see a little bit more how the pressure to just look a certain way. But I'm so grateful to be in this community where I build up an arsenal of body liberating kind of phrases.
Yep.
So they're very protective.
And you mentioned before about like the first bit that you did when you were a dietitian was around diabetes. So how did you find yourself in that area?
So I was, the first 6 months of my career as a dietitian, I worked in really general areas of a big hospital. It was at Wake Forest University in North Carolina. They have a pretty big hospital. I think it's like 1,000 beds. And so there were maybe 20 dietitians at the time working there. And so I got a really common first job where they just gave me all the cardiac floors and some outpatient nutrition stuff. But about 6 months later, one of the pediatric dietitians left, and that was kind of a coveted spot. Like those dietitians never left. And I didn't have any training in pediatrics, but I was like, ooh, that sounds interesting. And so, and those things didn't open up very much. So I was like, oh, I'll do it. And they're like, okay. And this particular pediatric nutrition job was really unusual because instead of covering floors, like hospital floors, I was handed a beeper and I basically was paged whenever the pediatric specialists, so picture like pediatric GI, endocrinology, genetics, like all the pediatric specialists, they all had their little clinic area. And when they saw their patients, not the inpatient ones, but just like the outpatient kind of clinics, whenever they needed a dietitian to come, they would page me. And so I just ran around all day working with these specialists. And the clinic that was the busiest was the pediatric endocrinology clinic. And there was only 2 pediatric endocrinologists at the time in the state of North Carolina. And so he was really busy. And I ended up working with a lot of kids at higher weights. He ended up, the endocrinologist, he ended up becoming someone who kind of was seeing a lot of kids in higher weights. And because he was an endocrinologist, he often was the one that was doing any kind of endocrinology workup to see if that was a part of the body size conversation. And, kind of got me into that place of really talking to more people at higher weights and finding out their lived experiences. And, so that kind of led me to get the certification as a diabetes educator and got me interested in just like what's going on with weight and like family dynamics I mentioned earlier. Just there were some really interesting things that I was starting to notice. Yep. And from there, I remember like I just don't know what to do because I'm not helping people. After like the first like 3 or 4 people, I'm putting kind of in air quotes, like it doesn't work, like either people aren't losing weight or they weren't coming back or something like that. A lot of times people are like, well, that's just because they weren't being compliant. But I'm like, okay, after like 10 people or 20 people or 30 people, like obviously there's something with me, like it can't just be the other people, I'm the common denominator here. And so I remember finding motivational interviewing.
Yep.
And so the pediatric endocrinologist and I kind of got into using that. And so he ended up being a PI in a study with the NIH and the CDC. And that got me connected with all these counselors because we got MI training. And this was back in 2000 or 2001. And
can you just explain just what motivational interviewing is, just in a brief
it will
just
be
so
brief.
people understand.
It will be brief because I don't consider myself an MI expert or motivational interviewing. It was my entry into counseling and mental health, but I don't consider myself an expert or a trainer in it. But it's a person-centered way of interacting with clients that allows the client to know that they're the ones in charge. I mean, I feel like that's what I still stick with. I'm definitely person-centered in how I work with my clients. And instead of me, the dietitian, barking orders, it's more of like, hey, what do you need today? How can I help? If at all, and these are some things that I found in research. What do you think about it? What do you think you want to do about it, if anything? And making sure that we again, it's framing it to be more of a partnership, or even really I feel like the client is the one that leads the sessions, and I'm just there to kind of help sort through and have them take the lead and me kind of go from there. So that's what I think of. I don't know if you have anything you would want to add about MI, but
no,
that's how I kind of picture it.
I would kind of agree with everything you said there. I'm trying to think what else I'd add. I mean, I would say in the same way as you, like, I know motivational interviewing. I've read the book. I more use it as an overarching principle, or the way I think about it, as opposed to more of a technique or following it by the book. Mm-hmm. But yeah, it's very much about using the person as a guide, finding where their innate motivation is, and kind of stoking that a little bit in terms of the questioning that you have. But yeah, very much having them be the ones that want to make the changes, and whatever the order of change is going to be, have them be coming up with it, which I know sounds kind of weird for people to start with, I guess, if they're like, well, you're meant to be the expert. But actually from a compliance standpoint, from getting people to be sustainable with these changes, it really does help. And since going that route for my own practice, I think I get better results. I think sometimes it's a little slower, but I think it's slower, but over the long term actually makes a lot better changes. Yeah. And I think that when you were talking about MI, I remember one thing that I remember learning about it was that it's not even really a technique. It is more of an orientation and informing how you do things. It's not meant to be this like trick, you know? And so, yeah, it sounds like for both of us, it like informs us, and we've added other things to it. And the people who are behind MI, I think they would be glad to hear that, you know? Yeah. So sorry, I took you off down this tangent. So you went and did that extra training, and then what happened when you then started to come back? So while I was doing the MI study, I started just talking to more therapists, and I realized I really wanted to still be a therapist. I still wanted to be trained as a counselor. And so I looked into doing that. I applied to a bunch of schools, and where I live, I didn't know it at the time, but literally half a mile from my house was one of the top 3 counseling schools in all of the U.S. I didn't know it was that highly ranked. I was like, oh, it's a counseling program. Oh, I'm going to apply to it. Oh, I got in. That's great. And then when I got there that year, they had been ranked number 2 in the nation. And I was like, oh, I should have been nervous applying to this program, but I didn't know. But anyway, it was hard because I had to say goodbye to that pediatric position, which I did for 3 years, where I was like bouncing around with all those different physicians. But it was wonderful because it allowed me to clinically learn so much about medicine. And where I was working, it was a facility that had residents and med students. So I got to learn a lot. And so I really appreciated it, but I also knew that I wasn't prepared. So that training took 2 years. And when I got done, I found a job. Actually, at this point in my career, I didn't want to do any work with eating disorders at all. I was like, I just want to work with food behavior. And I also had been living off $6,000 a year, which was hard for me to do. So I was like, I need a paycheck. And so I found a job that needed someone in a diabetes clinic to do be a kind of a counselor kind of role, like to run support groups and help people with just coping with the diagnosis of diabetes. But then they also needed someone to run the eating disorder side of things. And I'm like, well, I guess I'm going to like eating disorders now. And so I saw my first couple patients with eating disorders, and I was like, oh, no, I really like this. This is really wonderful. Like, this is something I should have been doing all along. And that's when I really started to move away from specializing in diabetes and more into eating disorders. And I mean, honestly, that's how PCOS and me kind of really got connected. Is I didn't want to do anything else with medical kind of conditions unless a person had an eating disorder. But I just kept getting so many people with eating disorder who also had PCOS. So I was like, well, I guess I got to figure this out because nobody else is doing this. So let's just figure this out. So then we can have something to like tell people to like help heal their relationship with food. And
So yeah, it was kind of a messy time, but I'm really grateful for it now.
And with that overlap between eating disorders and PCOS, I mean, I've had clients who've been given a diagnosis of PCOS, then because of the recommendations around that in terms of you need to lose weight or you need to go low carb or whatever the dietary recommendations were that was often given to them by their doctor, that then kind of took them down the route of disordered eating, potentially even ending up with an eating disorder. So is that often the picture of how it was presenting for you, or it was different?
Yeah, definitely. What I noticed was that so many of my clients with eating disorders, whether they had PCOS that was diagnosed or it was undiagnosed, kind of because sometimes it would just kind of come to the surface as we were working together, that the focus on weight and not everyone with PCOS, but many people with PCOS end up having a larger stomach. For some people, it's just how the condition is experienced. The high circulating insulin often is one of the reasons why people say that happens. But so a lot of my clients with PCOS, they were told, like, you need to lose weight. The weight caused this, which is not true. I say it with so much firmness, but no, it's not. That's actually false. But people were told that they caused it by their weight, or they ate something wrong and that caused it. Kind of a similar script that we often will hear with diabetes. Yeah. And so yeah, people were doing everything that they could to comply. My clients with PCOS would tell me, I'm not going to name the amount of calories, but they were eating way below the amount that their body needed just for like their liver, and they're like, I'm not losing any weight. And they would tell their doctors or healthcare providers or dietitians, and they either were just like, you just need to try harder, and or they just weren't believed. And I know some people, they would tell me like, oh, my doctor told me to eat, I throw out a calorie amount that I've often heard, like 1,500 calories. And, but they're like, they didn't ask me actually how much I'm eating, and I'm eating half of that. And so like, and I'm still not losing weight. So how do I do this? And so for most people, when you like go through starvation, for most people, it doesn't just stay starvation, because the human body is wired to survive, as we know, right? And so through evolution, we've figured out ways to like, hey, you need to eat now. Like that we like dream about food, we think about food, we get hunger, cravings, all these things that our body does just to let us know, hey, you need to eat or you're going to die. And so our clients with PCOS that were cutting out just so much food, whether it's calories or carbs or over-exercising or all those, eventually there'd be a time where like they would just start eating, and it would be like hard to stop, because, if you're on a deserted island and food falls from the sky, you're going to eat it all. And so that's what the body thought. And so, for a lot of people, then they felt so ashamed of that kind of experience. And so then a relationship with food that was more of a binge restrict kind of cycle started happening. And, for the majority of people I work with PCOS, that's kind of the kind of path that they experience that leads them to an eating disorder. And of course, not everyone looks like that, but that's probably the most common. Okay. And the thing that's such a bummer about it is, the quote unquote binging, or that feeling out of control or feeling addicted, or the emotional eating or stress eating, whatever people want to call it. However you identify it, in the end, really, that's what's saving a person. It's keeping them alive, but it's the thing that has the most shame. And that's where we need to handle with care, and say like, again, this is saving you. And that's where I've seen my role since I started working with PCOS is like, okay, like how can we help people first know that we believe them, and then also like, let's help you figure out what you need to feel better. And that's what's going to promote health.
Yeah, definitely. And I think as you said there, framing it as like, this is a body response to restriction. Like this makes complete sense. I mean, I've done 2 whole episodes on the podcast all about the Minnesota starvation experiment. So people can definitely check them out. I'll put them in the show notes. But yeah, I go into great amount of detail about what happens as part of that. So I want to back up a little bit and just start with like the basics of PCOS. So what is PCOS?
So the PCOS definition that I think is important to know is that it's an endocrine disorder that has reproductive, metabolic, and psychological consequences. So, yes, it's called polycystic ovary syndrome, so the ovary's in there, but it doesn't just affect someone's reproductive system. And it doesn't actually even start in the ovaries. Some people don't have any effect on the ovaries so they need to change the name.
Yeah.
But for right now, PCOS is what we got. And so the reproductive consequences of PCOS often look like heavy periods or painful periods or infertility. And I feel like that's what most people will think about with PCOS. It is the number one cause of ovulatory infertility. And, but yet not everyone wants to have babies. And oftentimes when people get diagnosed with PCOS, the doctor's like, well, here's birth control and come back when you want to get pregnant. This is all I got for you, which is a big bummer because there's lots you can do and not everyone wants to get pregnant. So what are they supposed to do? But there are metabolic consequences, and that looks like the insulin that I was talking about earlier, the insulin resistance, high cholesterol, high blood pressure, kind of a metabolic syndrome type of experience is pretty common. And then there's also psychological consequences. So PCOS, what the research is pointing towards right now is it probably starts in the hypothalamus. And one of the very first signs of PCOS is a mood disorder before puberty. A lot of my clients with PCOS will often say, oh, yeah, I definitely had a mood disorder when I was 8, 9, 10. Part of the PCOS experience is it messes up with hormones, and our mood is directed by hormones. And so depression, anxiety, ADD, bipolar disorder, those are all things that are related to mood, or those are mood disorders. So people with PCOS oftentimes will have that. And I do feel like the mood disorders I see with PCOS are different than people without PCOS. Especially the anxiety piece, the anxiety seems to be much more intense. And, things that normally would treat anxiety for other people, it doesn't, it's like, it just, the PCOS brain just laughs at it. It's like, no, that's not going to do anything. And, I was talking to Christy Harrison on her podcast a few months ago on Food Psych, and she mentioned, we were just talking about that part, and she was like, that's really interesting because I wonder how the insulin resistance has to do with anxiety, which I was like, I had never really thought of this. This is because of the insulin resistance, basically the body's not able to get enough nutrition because it's not able to use the glucose, the cells are starving, and so then the body may even just be in this place of anxiety because it's not getting nourished, And I don't know, to me, I'm like, that is such an important connection, maybe it has something to do with it. And to me, why that's so important is because the pressure to lose weight and all the weight cycling that people with PCOS experience is probably making their anxiety worse, along with all these other things. But it's probably something that's leading to the mood disorders. And that, again, that's just conversation theory and things like that. But I think there's something to that.
Yeah.
So, yeah.
And I wonder then, has there been any studying, if I'm thinking from a cells energy perspective, has there been any studies looking at mitochondria of people with PCOS versus the general population and how that's affected?
I don't know. That would be interesting because that would not be a research study that I would be like, that would be something that sounds very detail oriented, right? But important. And I have a feeling there are some studies like that. And there's probably someone listening who knows exactly the ones that we need to read. But yeah, I don't know of anything in that area. Okay.
And so you mentioned there's kind of three main buckets that get affected. So you've got reproductive, you've got metabolic, and you've got the sort of mental side of things. For the people who have it, how often will it be in just one of those, in two of them, in all of them?
I think, well, it depends because there's different there seems to be different types of PCOS, but for the most part, most people I work with have sort of all three in some way, or they will at some point have all three in some way. And I say that kind of loosely because there are some people who really don't have any reproductive consequences associated with their PCOS. That's not the typical PCOS, but it certainly is some people's experience. And so yeah, that's just something to keep in mind. And as I was saying this, I'm like, I forgot to mention even another part of the reproductive side of PCOS that is important is hyperandrogenism. I cannot say that word. High androgens is something that's a clinical part of it. So people with PCOS will have higher circulating testosterone than people without. And that is one of the reasons why things like ovulation is affected. And it also affects things like appetite and may also have something to do with insulin levels as well. But yeah, something I just forgot to mention that I think is important because basically getting diagnosed with PCOS is kind of this weird experience because it's a diagnosis of exclusion. And so they kind of have to rule out a bunch of things. And if those are ruled out, well, then, you may have PCOS. So people oftentimes kind of have this period of about a year where they're like, do I have it? Do I not? What do I do? And but having high circulating testosterone for some people is one of the diagnostic criteria that'll kind of seal the deal for them.
And so what are the different diagnostic criteria for it?
So the Rotterdam, oh my gosh, I can't believe I'm not pronouncing that correctly, criteria is there's the person would need to have 2 out of 3 criteria. And one of them is evidence of high circulating of high androgens. So it could be high testosterone, or it could just be evidence of high testosterone, which could be an increase in facial hair or hair loss. Another one is some kind of issue with menstruation, which it could be like no periods or irregular periods or heavy periods. And then the other one is cysts on the ovaries. So, and then there's also a couple conditions that need to be ruled out. But those 3 criterias right there are if someone has 2 of the 3 of those, then they have PCOS by those criteria. And those are still the most recommended ways to diagnose it. There were some new guidelines released in 2018 that started to hint at looking at a different hormone, but there's just not enough evidence yet to use it. So for right now, that's still the most up-to-date way to get diagnosed. Okay.
Because even like if I'm thinking about that, there's probably combinations I could come up with where you had 2 of the 3 that had nothing to do with PCOS.
Yeah.
I take out the high androgen. If you've just got someone who's got irregular periods and someone who's got cysts or the immature follicles on their ovaries, I mean, hypothalamic amenorrhea would come as part of that. Someone who is in their teenage years could be falling in that category as well.
Well, yeah, there's kind of a catch with that because when people are diagnosing it, I don't diagnose since I'm a dietitian, but I can strongly encourage a doctor to diagnose. But that's about as far as I can go. But it's not encouraged to diagnose PCOS, or it's kind of wishy-washy until a person's 8 years post starting their period. So, especially using a different guideline that they're trying to develop right now because of that, because there is some irregular periods that is just kind of common, and has nothing to do with having PCOS. But yeah, that hypothalamic amenorrhea, I think is such an important part of this conversation because so many people are not asked how they're eating when they get that blood level of testosterone taken. And so doctors are like, oh, you're not having a period and you have high testosterone, you must have PCOS. But if they just said, oh, how are you eating while you're training for this triathlon or whatever you're doing, then they would be like, oh, you're not eating enough, And so for some people I've worked with, that's what has ended up happening. It's really just been, it's been malnutrition has been the basis that's caused the high testosterone. And so as a person eats enough, then it normalizes and goes away. So yeah, I feel like one of the best questions as healthcare providers we can ask people is, how's your eating?
Yeah.
It's a simple question, right?
Definitely. And you mentioned about the fact that it's got to be 8 years post someone first getting their period. Is that a new recommendation? Because I've had lots of clients who were diagnosed in their teenage years who, as I said, went on to then develop a fairly disordered relationship with food. And in the end, they don't think they have PCOS anymore.
Right, right. And, the 8-year thing was based on using the, it's an AMH hormone. I can't remember,
Millenarian?
Yeah. Yep. Yes. Thank you. Hormone. And so, it's really, you can't, it's looking at that research that we're saying post 8 years. And so, it's one of those things that's kind of still murky and gray. And I don't know how long people have been talking about that honestly, but reading through the new evidence-based guidelines from 2018, that was one of the things that was talked about in there. Okay. And so that was newer to me reading it, but I don't know. It's probably one of those things that was not newer to some other people, but it was newer to me.
Okay. And
it makes sense, right? I mean, it doesn't mean you can't get diagnosed with it, but it just means like, hey, we need to wait and see. Or we need to figure out a better way to diagnose people.
And in terms of the cysts or like the immature follicles that haven't developed properly yet, is there an amount? Like I seem to remember something that for it to be PCOS, there has to be more than a certain number on one of the ovaries or each of the ovaries to kind of differentiate between, okay, is this just sort of fairly normal or is this kind of getting to more of an extreme end of the spectrum?
I don't know. I always just hear it called like the pearl-like cysts, like you said, quote unquote cysts, those immature follicles. So I don't know how many it has to be.
Okay.
Yeah.
Fine. Yeah. I'm trying to remember where I've read that. It might have been with Nicola Rinaldi's work. I know she's done a lot on HA and differentiating between the two of them. And I have a feeling she referenced something along those lines.
Yeah. I love her work.
Yeah. And so in terms of like what causes PCOS, I imagine your answer is going to be we don't know. But what do we know about the causes?
Well, what we do know is that weight does not cause it. We also know that how a person eats doesn't cause it. So I just want to make sure that any listener that experiences PCOS knows that they are not to blame for it. So far, there's like a genetic kind of connection. It's definitely passed down through families. There's probably some kind of environmental part as well to it, kind of like just any other kind of disease out there, right?
Yeah.
Even though PCOS is not considered a disease, more of a syndrome, right? But still, it's it has kind of this mix of genetics and environment with it. But yeah, it's not nobody caused it. They didn't do anything to cause it, And so for right now, that's basically all we know. Yeah.
And in terms of when you say genetics, where they've been able to isolate certain genes, so I know you can do genetic testing for different things, like to that level or no?
I don't think they know it on that level yet. When I work with people, this is something that's more of like practice-based evidence, but most people I work with, they find it's been passed down through their father's side of their family. Okay. But you'll see other research that talks more about the maternal side. But it's definitely has some kind of genetic connection, but I don't know. And I'm definitely not a genetic expert. So
sure. And in terms of environmental factors, is there any specific ones that can be pointed towards? Like, okay, this tends to make it more likely?
I think that's something that I would love to see more research on. The person who did a lot of my training, Monica Woolsey, she often talked about how the agriculture change that shifted in the 50s and 60s with changing how we feed our livestock. That was something that changed a ratio of omega-3 to omega-6 in our food. Yep. And so she often talked about that and how it may have an effect on the amount of people experiencing PCOS. I think also there's more people in the research world connecting to trauma and intergenerational trauma and the PCOS experience. And many people with PCOS, there's a lot of trauma in their history, whether it's racial kind of trauma, marginalization, that has been passed down from centuries, and how that may also have a connection to the environmental side of it. So I'm really interested to like see that research. That's the one I'm really looking the most for, is the trauma and the PCOS experience, like whether a person gets it or not. And, so that's something that I think is, again, it's not something that we cause, it's just something that happens, but yet explains why, some people have had it passed down,
Yeah. And so I've done like a podcast before on the adverse childhood experience study, and I'm trying to remember, but I can't, if they looked at the incidence of polycystic ovary syndrome and then the various numbers of adverse experiences and how that would have an impact on it.
Mm-hmm. And as we're talking, I noticed that there's someone mowing the grass right next to me. Oh my God, it just got really loud. Okay, hopefully they're done. There's like only one little strip there. But anyway, that I don't know. I think about how stress is related to blood sugar and insulin levels, and that would be really interesting to really sit with and sift through and see if we can connect some dots.
Yeah, definitely. And so, what is the amount of people who are dealing with PCOS? So, what percentage of the population? Yeah.
So it depends on where you're looking at, like what the numbers are, but you'll see anywhere between 1 in 5 and 1 in 10 of those assigned female at birth experience PCOS. Not all of them have been diagnosed, but that's the estimation at this point. The most common I'll see is 1 in 7 of those assigned female at birth experience PCOS.
Okay. But even at 1 in 10, that is a lot of people.
Mm-hmm. Mm-hmm. For sure. It is. It's a lot. And for as little we know about it, I mean, it's kind of ridiculous, right?
Yeah, definitely. And does it, I mean, you talked about the fact that, okay, maybe the changes in agriculture from the 50s or whatever. So is it getting more, like, is there more cases of it? And if that is the case, is it just we're getting better at diagnosing it via ruling things out, or it is getting more common?
I don't know the answer to that, because it's kind of one of those things that I think is related to other conditions that we're like, wow, why are we seeing more of this? And really, it's probably because we're diagnosing it better. Yeah. I don't have a scientific answer for that. I probably would just be guessing.
Okay, sure.
Yeah.
And are there other conditions that are common alongside PCOS? And I know you talked about sort of mental health issues or issues around sort of metabolic syndrome type stuff, but are there other diseases that seem to come along quite commonly?
Yes. So what most people will think about is diabetes. 40% of people over the age of 40 with PCOS are experiencing either prediabetes or diabetes. And so what we'll also see is high blood pressure, high cholesterol, and of course, infertility. But something else that is super common along with that is one that I just lost my train of thought with. Let's see, what one was it? PCOS and, oh my goodness, I had my first brain fart. Excuse me, Chris. So conditions with PCOS besides diabetes and, it'll come back probably when we're talking about something else. But. Okay,
perfect. That's fine. And something else you talked about before in terms of, okay, it needs to be 8 years post someone's first period. So is there a way that you could diagnose PCOS like before someone has started to get their periods, or even at the other end of the spectrum when someone's gone into menopause?
Technically, no.
Okay.
Like if you use the criteria that we were talking about earlier, that's one of the things that I think is really unfortunate about it. One of the many is that especially people post-menopause, or they just technically cannot get diagnosed with it. And some people think that once they get they get their hysterectomy and they're like, oh, well, I don't, and they got the ovaries removed too. They're like, I don't have PCOS anymore because I don't have ovaries. Well, no, because it doesn't start there, and it's something that a person will have for their whole life. And it's chronic, it is like diabetes in that way. Is chronic conditions are something that like it gets worse and worse, and not even if someone does whatever exactly is supposed to be right, we don't even know what that is, and we're not robots. But even if someone did, like, it still gets worse because it's a chronic condition. But yeah, so as people are living with it later, post-menopause, the metabolic and the psychological consequences are still there. But that's the AMH levels. That's where that could be really helpful, because that is something that the researchers could use to diagnose it pre-puberty or period really, and post-menopause. That's how they actually could get diagnosed early on. Yeah.
I mean, I don't know a huge about AMH, but I mean, I know for clients I work with HA, there's been times that when they are in the thick of their over-exercising and under-eating, they went and had their AMH checked, and they were told, well, you just have low ovarian reserve. It means you're just entering early menopause. And then once they started eating more, taking the time off exercise, and their body got back to being able to support itself properly, their AMH levels were in the range that it should be.
That's so interesting.
So I wonder, how much other variables could then impact on that as well.
Yeah, I don't know as much about AMH, so I don't know how it's affected besides, how the person's eating and moving their body and how stressed they are, and when I say stressed, I don't mean like marginalization, not like you need to go meditate, but yeah, I don't know how AMH is related in that way, and how that would be seen then in PCOS diagnosis. Yeah, because it sounds like it's not a something that is just the same no matter what. It sounds like it can vary.
Yeah. And so you alluded to before that there are different types of PCOS. So can you talk a bit about that?
Yeah. I actually have a really good blog post. I had a nutrition grad student that worked with me for a couple years, and she is someone who has PCOS. Her name's Kimmy Singh, and so she wrote this really wonderful blog post on the different PCOS types. And I'm going to pull it up right now so I can give you the actual.
And she's the person you do the podcast with as well, right?
Yes, and so there's 4 or 5 different types that of PCOS that have been discussed, and I'm looking for the actual website right now, or the link, and I don't have it. I may find it as we're talking, but anyway. So basically what that means, like the different types will look like, is some people with PCOS, they have like the period issues, and then they may not have any issues with hair on their face. Or there may be someone that has totally normal fertility, or when I say normal, I mean they're ovulating as expected, yet they have lots of insulin resistance. I mean, there's just different types. And for a long time, we just thought people with PCOS all had the cysts around the ovaries, and they had high insulin levels, and they were losing hair on their head. But really, when it comes down to it, that's just one type. And so there's many different combinations based on those 3 criteria, like you said before. And I think it's just important to keep that in mind, that not everyone looks the same. Like, you definitely can't diagnose it just by looking at someone. You really need to you may have some clinical clues by looking at someone, maybe like if they're losing hair on their head or something like that. But really, besides that, we need to make sure that we actually are doing an assessment, again, including like, how are you eating? So we can figure that out. And if you're wanting to know more about the different types, if you go to juliedillonrd.com/PCOS types, it'll take you to it. And what Kimmy did, because she's the one that wrote this blog post for me, is she made a kind of chart about the different types. And, I think it's important because there's, there's a lot of like shame that comes with PCOS. Yeah. And I mean, it's an ovary thing. It's a period thing. It's a woman thing. And so if a person feels like weird already, and then they're like, well, I don't have the classic symptoms. And then sometimes doctors will be like, oh no, you don't. Like, I've had some people be like, my doctor said since I have blonde hair, I can't have PCOS. I'm like, oh geez. Well, first of all, like, how do they know if you diet or not? And then, but like, that's to me was like hilarious. Like that, like we are not a species that are like, I don't know, it's all like we have fences around each other. So like if it's in more in one population than the other, like we all are hanging out. So anyway, yeah, so we all can kind of look different, but yeah, check out that blog post because I feel like it's a really helpful one just with all the different types.
Okay, cool. And would it mean that depending on which type you could approach it differently in terms of how you would deal with it?
So, what I think about that, is we know so little about PCOS that we don't even have, I know we have these evidence-based guidelines that I've referenced a few times, and it's like 200 or 300 pages. So it's definitely long. But when it comes down to it, especially with food and movement, we really don't know long-term the way to treat it. And we don't really have enough research to have some medications that are intended for PCOS. There's lots of off-label uses of medications, but we don't really have that much information. And so using this kind of chart is helpful because if you can kind of place where you are on it, you can kind of know, okay, so I'm someone that doesn't really have as the higher androgens. So there's some things that people talk about doing, like birth control is sometimes what people take to help lower their testosterone levels. Inositol is a supplement that a lot of people take to help lower their testosterone levels. And so someone's like, well, I don't have the higher androgens, so I'm going to wait on that, which I think can be helpful. And that's more of a didactic thing. But what I really think is important for people with PCOS to know is that you are an individual and we don't have enough information to give you exact tools. So just know there are different types and you and your body need to decide what you're willing to do and what works for you. And that there should be a hard stop on it. Nobody else, you get to decide what you're going to do and what choices you're going to make and what works for you and what doesn't. And if it makes you feel like it's torture, then that I would not do that, and I'm mostly speaking about the diets that people are told to do. People are like, oh my gosh, it feels like hell. And I'm like, yeah, it probably does, and, so don't do it anymore if it feels so bad and you and your body get to decide. I have a feeling many years from now, they're going to have more specific types of PCOS and different ways to treat different types of them, but we just don't have that information yet. So using your own body as the way to help you decide what treatment, I think, is the best route.
Definitely. And I mean, what you described there sounds like a combination between motivational interviewing in terms of getting the client to work out what they want to do, as well as intuitive eating in terms of listening to their body to figure out what option they want to be taking.
Yeah.
And you mentioned there about sort of misdiagnosis or you can't possibly have it because you've got blonde hair. My experience with clients has been sort of misdiagnosed in terms of people told they do have it when it really turns out that they don't. But I wonder how often it's kind of the other way around where people are told, oh no, everything's fine, or we really don't know what's going on, when actually it would be helpful for them to be given the diagnosis of PCOS.
Mm-hmm. Yeah, the misdiagnosis definitely happens. That's another thing that Christy Harrison and I were talking about because she was misdiagnosed with it at some point. But the most common experience that I see with my clients is that they are either not told that they have it, but they do. Doctors will know that they have it, but they just don't give them that information because they're like, well, what are we going to do with it? And or they're like, they just don't really want to pursue looking into it. And for a lot of people that I work with, they'll come to see me because they have this complicated relationship with food, and they will be basically weight suppressing themselves. They're going through starvation, maybe having a chaotic relationship where there's some binging or what they would call binging, but again, I just call staying alive. And so there's weight suppressing that's going on because there's just not enough total amount of energy going in their body. And so their body looks smaller. And so sometimes doctors will be like, no, you don't weigh enough to have it. And my big thing is seriously, to get a testosterone drawn, how much does that really cost? I mean, in the US, that's a really inexpensive test. And so, I'm like, can we just get that? Because I mean, and I know that's not the end all be all, but it could really be helpful just to have some kind of way to kind of have something concrete to hold on to. But yeah, there seems to be, and then this is where my feminist ideals and like foundation kind of come through. But I get a sense that there are some people who just don't want to tell people that they have this condition because they're afraid of how they're going to react to it. And this is actually something that was talked about in an editorial column, it was 2 or 3 years ago. And I want to say it was an Australian journal. So maybe you know more about it, but it was an editorial on that. Maybe we're just overdiagnosing PCOS, and why should we even tell people when they have it if we're not going to do anything about it? And, that's outrageous, because I think doctors don't really appreciate, and healthcare providers, I don't want to just keep slamming doctors, but healthcare providers don't always know what to do, but that doesn't mean that a person shouldn't know about it. And it's almost like this, those of us who are socialized as women, like, we're just so weak, we can't handle this. And so, no, we can handle it. And the truth is important. And so, I think there's more people who are needing the diagnosis, and there are people who are undiagnosed. And if people get the diagnosis earlier, there's so much that they can do. And especially from my point of view with specializing with people's food behavior, if someone is like, this is why I have cravings, or, this is why my body's changing. Let me be kind to my body instead of fighting it. My body's trying to tell me something. I think it could help not only with just preventing an eating disorder, but like body image, poor health, weight cycling, and then like how you're raising your family, how you're teaching your children about eating. And it ends up being this really big, important thing to just know about your body. So, yeah.
Definitely. And like even if you can't like cure PCOS, there's a lot that you can do if someone gives you that information. Mm-hmm. I mean, I think the same way I work a lot with hypothalamic amenorrhea, and so often women are told, we don't know why this is happening. It's not really important. Just go on the pill, come back to us when you want to have a baby. And it's like, no, but there are some real repercussions to this going on and not doing anything about it. Right.
Yeah, there is a parallel there. That's true. Because that's a lot of people with PCOS tell me that they are just given birth control. Yeah. Like this will make you have a period. And there's some things with birth control too, like, that some researchers are pointing that may not be the best choice for PCOS. That there's some connection with higher insulin levels with long-term use. I'm like, well, geez, people with PCOS are already, for a lot of people, that's a big part of their experience is this higher circulating insulin. And so that could be just making it worse, and then, it's not fixing anything. It's helping to lower testosterone. And for some people, it's providing birth control, which important for them, or making periods just more easy to live with. But besides that, it's not fixing it,
Yeah, definitely. And you said something before about doctors saying, okay, you're too thin, you couldn't possibly have PCOS, or you don't weigh enough, you couldn't possibly have PCOS. So I think within the culture, maybe there's this idea that it skews that way, that people with PCOS are typically heavier or there's high weight. Like, is that true within the research?
The research is basically, it's funny because when we look through like those evidence-based guidelines that were published in 2018, there's so much talk on preventing people from going to a higher weight, but yet they even state in there that basically the percentage of people with PCOS who are at higher weights is the same as the general population. So it's not any different. And which I think funny, but it's definitely what I see in my practice. It's just like bodies are all different, and people with PCOS all have different bodies too. There's kind of if someone has what they would call the classic PCOS type, where there's high androgens and the metabolic consequences with PCOS, when people have the high circulating insulin, and if it's been going on for a long time, having more fat in the stomach area is a really common experience, but it's not what every person has. Everyone's body is different. So yeah.
Okay. And so what are the conventional recommendations for PCOS? I know we've probably touched on some of them, but just as a starting point, what are most people told that they should do?
So the primary recommendation, and through all those guidelines that have been recently published, and if you look at any general body of like the American Society of Reproductive Medicine or OBGYNs, like the general recommendation is still weight loss, lifestyle management, whatever somebody wants to call it, but basically the same thing. So either lose weight or don't gain weight is what is recommended, along with restricting carbohydrates and or sugar, and then of course movement or exercise with that as well. So there's a big push for lifestyle modification, and I'm using my bunny ears with that too. Lifestyle modification, and they base that on this wonderful, and I'm being so sarcastic, wonderful long-term research in PCOS. This long-term research is 12 weeks long, that show that starvation can change insulin levels. Well, yeah, of course, if we're not eating, it's going to cause our insulin levels to go down. But then long-term, we know from general research outside of PCOS that it just makes insulin higher. But anyway, so yeah, the general recommendation is to lose weight or make sure you don't gain weight. I had the pleasure of interviewing Caroline Dooner. She's someone that experiences PCOS, and she wrote a book. I don't know if
you can swear. I know the name of the book.
The book. Okay, so her book is The Fuck It Diet, which is a really wonderful book. I mean, she's not a dietitian or nutritionist. She's not a clinician. She's someone who has a lived experience, and it's really good. Like, it has a really great review of the literature. I like it better than I think like most nutrition ones right now. It's like kind of my favorite one. But anyway, I interviewed her on the PCOS and Food Peace podcast last year with Kimmy, saying, and the thing that she told me, it was that when she got diagnosed with PCOS, she was already starting to experiment with her eating disorder, but it wasn't like totally set. But once she was told she had PCOS, she was told she had to diet. Like, that was basically like, you have to diet now. You cannot like lose control of this. And you can just never eat too many of whatever. And she's like, that was it. That was what clicked it all into place. And the eating disorder really had this foundation because she had to now. And it's really unfortunate because even in the guidelines that we read, they talk about like, we really don't have evidence that shows any certain diet is better than others. So kind of recommend any of them. That's basically what it says. So like, hey, none of them really have any evidence working long term, but so just throw out anyone you want instead of like, wait, maybe we shouldn't recommend that.
So throw out anyone you want with the intention of trying to lose weight.
Right. Or just to manage like lifestyle management kind of stuff,
Okay.
Whether it's preventing diabetes or preventing weight gain or lowering insulin levels. There's like a mention in there of like, we don't have any long-term research that any diet that works long-term. So really just choose whichever one you want.
Okay. Because one of my questions when thinking about this was if it's useful to get someone to go lower carb or reduce carbohydrates, but still keep calories at the level that they need to be at, i.e., bumping up your protein or bumping up your fat, but keeping carbohydrates low. Like, is there any validity to even that?
There's definitely there's some 6-week and 12-week studies in PCOS that show that it is helpful. They show that it improves ovulation and egg quality. But yeah, past the 12-week mark, I haven't seen any yet. And with PCOS. And what I do know in the long-term research for the general population is that that doesn't work. And then, when I'm sitting with a person, again, we're doing person-centered care, a person will tell me, well, I tried that, but like it felt like torture. And I think that's a really important part, especially for those of us who don't have PCOS, to keep in mind is, having a food craving when we don't have PCOS, it's kind of like, I have a hankering for something sweet. I'm going to go have something sweet. And I just, a few bites or a candy bar or something. But when a person with PCOS when they've taught me about their cravings, it is not they may use the word craving, but I feel like it's so much deeper, it's more primal. It's like, I have to eat this right now or I'm going to die. And so if you're like, okay, but you can't eat that. So just imagine if we need water and you're like dying of thirst, but they're like, oh, that you can't have any more water, but like you're dying of thirst. So how would that feel, And so of course it's not sustainable because it's a primal need that's not being met. So yeah, like to me, I'm like, well, until there's some evidence that there's a way of like restricting something that actually long-term helps for humans, then it's just not something I'm going to entertain to help my clients with. And I think like removing carbs and sugar for PCOS, again, maybe in the short-term research, it does something, but I really feel like it's kind of like putting the cart before the horse kind of thing. It's not something that's really going to go to help healing what their body is missing out on and what's so depleted. And I have like a 12-step system that I take people through when I work with them and in my online course. And I go through so many things, like, let's make sure you're eating enough first. Yeah. Let's stop weighing yourself. I encourage people to experiment with eating more protein, not taking carbs away, but just experimenting with eating more protein and then adding some supplements. I think it's either step 8 or 9. We talk about carbohydrates. So like it's like way near the end, and when we talk about carbohydrates, by that point, for most people, it's not even something that needs to be really sorted out. Like once the body has found a tool that helps lower insulin levels, if that's something that they're experiencing with their PCOS, once they're lowering insulin levels and their body's eating enough food and getting repleted in that area, then the carb thing it doesn't seem to matter. Mm-hmm. And when I say that, it may mean like it doesn't really matter how much they have or their food cravings. Some people, they may end up eating less carbs, but they just don't want them. And they have permission for them. I hope they do, because that's a big part of how I'm doing this. But like, it may look like some of the recommendations, but it's coming from a different place. It's like, oh, it doesn't even sound good. I don't want it. Yeah.
And it's interesting because I work a lot with clients who have gone through the real, just decades of dieting and have tried lots of different things. And sometimes things work for quite a while before they get really bad. So they become like, they go low carb and they become very evangelical about it, and it works for 6 months or it works for a year. It could work for even longer than that. And then everything starts to really become a problem. Mm-hmm. And so I'm like, as you're describing those like primal cravings that people get with PCOS, maybe the people who do well on PCOS with a lower carb, at least in the beginning, are the people who skew more towards the non-metabolic issues with PCOS.
Mm-hmm. Yeah. Or it's their first few diets,
Yeah, you've got the honeymoon part.
Yeah. Like I feel like a lot of people that I work with an eating disorder or disordered eating in their history, like they could do it for the first few times, at a 6-month stretch. But then after the 5th or 10th or 20th diets, they don't last as long because the body just is too tired, and the cravings are so much more intense. Yeah.
So I know you said you go through like a 12-step program, mm-hmm. a 12-step program with people.
Yeah, that sounds like a good word for it. Yeah.
So can we just touch on some of those different things? Like what would be some recommendations as part of going through it, and we can dig into a couple of just in a little bit of detail?
Yeah. So the first 2 have to do with moving away from dieting and checking weight. And not everyone I work with is excited about that. I don't ever, I'm upfront with people where I say, hey, I don't put people on diets, or I don't support diets, or, whatever. But I also believe in body autonomy. So a person gets to decide what they're going to do. And this way of looking at PCOS, I ask people to give their body 3 to 6 months without the pursuit of weight loss, just to see how they feel. And, I'm really rooting for them to not go on a diet, but I also appreciate people are getting marginalized every day because of their size. So, they get to decide what they're going to do. But from this approach, making sure a person's eating enough, that really means moving away from dieting, not weighing yourself anymore. I also, in the next couple of steps, I talk about using a couple of supplements that I find that are really helpful for people with PCOS. And one is repleting omega-3 stores in the body. There's a pro-inflammatory state that is being found in research right now with PCOS. It's kind of this chronic pro-inflammatory state, and maybe behind some of the insulin issues and other hormonal abnormalities, and also leading a person just to feel like crap, just feeling so tired. So many people tell me, they're like, I have no energy whatsoever. And part of it is because of the weight cycling. It's repleted or depleted, specifically the DHA stores in their body. And so getting some supplemental DHA and omega-3. And then the other one, inositol is another supplement that I recommend. And I briefly mentioned it earlier, and I always have to feel like I need to say, like, I'm not typically someone that recommends a lot of supplements. I often roll my eyes when I talk about recommending supplements because I can't believe I'm recommending them. But I was in college when the FDA in the US changed the regulations to not regulate supplements. So I remember being a really big deal as a dietitian in training to not recommend supplements because they weren't being regulated. And the amount of omega-3 that a person with PCOS needs just to recover from weight cycling and dieting and just the PCOS experience is just so great that they need it from a supplement. And then this inositol thing. So inositols are a part of B vitamins. They're secondary messengers, and they're really interesting. If anybody listening, or for you, Chris, if you're really into following something in research, I feel like inositol research is one to watch with PCOS because it is something that may lead to not necessarily a cure, but just some really big deal with it. And right now what researchers are thinking is that people with PCOS either have a defect or a deficiency in these inositols. And so we have 9 different types of inositols in our body, and there's 2 different ones that researchers have been able to connect to PCOS. And if a listener is like, this is so confusing, I'm here with you. I always say I loved biochemistry so much I took it twice. It's not something that was ever my super. It takes me a long time to really soak in biochemistry. I think it's important. But Kimmy, my nutrition grad student that worked with me, she wrote a really great research-based article on inositol. You can get on my website too. And but basically, finding a way to supplement with inositol is another thing that's a part of those first few steps. And you can get some that are naturally occurring in plant-based foods, fruits, vegetables, beans. Those are all things that have naturally occurring inositol, but basically a person still needs more than they're going to be able to get. And inositol has a really cool kind of connection to insulin levels. And so by increasing inositol, it basically does a lot. Our clients with PCOS who are feeling just so fatigued and having lots of those cravings, they'll tell me within about a week of using inositol, many people, not everyone, but many people can tell within a week. They're like, oh my gosh, I feel so much better. I can tell already. And it's recommended to try it for 90 days before you decide if it works for you or not, because it may take that long to affect ovulation. But that's a really exciting one. And I do think that some pharmaceutical company is going to come in and make a pharmaceutical grade version in the U.S. and so it'll be super expensive eventually. But for right now, it's still online and you can get it on your own in the U.S. and actually anywhere in the world. But so those are the first
with the
couple.
research around that, is there more because it then isn't applicable not just to PCOS, but also to diabetes and metabolic syndrome?
Yes. Yeah. Yeah. It's something that I recommend to people who have any kind of issue with insulin levels, whether it's diabetes or just their insulin levels are high. It's something that is recommended, or it's suggested in research that it can be helpful. Also, people with anxiety. There's some research that it can help with that as well. So super exciting for sure.
Okay.
Yeah.
And just out of interest, did all your years of doing that work around diabetes, has that been helpful now with PCOS because of, some level of overlap?
Yeah. Yeah. Cause I did so many pump trainings and new diabetes trainings, because I was the diabetes educator for this 1,000-bed hospital. So if any kid came in with new diabetes, I came in, whether it was a Saturday or a Tuesday. I was going to be there talking to them about having diabetes. And so, I got really good at being able to explain, this is what insulin does. And so it's been really helpful. And also, working with diabetes and kind of on, from a more weight centric approach, I got to know both sides of it, and so I kind of I can appreciate why people are recommending a weight centric approach with diabetes, and I know it doesn't work. So it's definitely helped inform. The one thing as you probably can appreciate is since I haven't been doing it for a while intensely, I'm not up to date on a lot of diabetes medications. And so when my clients with PCOS, if maybe they don't tolerate metformin, which is medication a lot of people with PCOS end up getting put on, if they don't tolerate it, they may need to find another way to help treat some of their symptoms. And I'm like, I just don't even know what medications are out there for diabetes anymore. So those are ones I often will need to refer out because I just don't have that in my toolbox anymore. Those medications change so much,
Okay, fine.
Yeah.
And in terms of, like you mentioned about omega-3s, I mean, my recommendation, and this isn't specifically around PCOS, so I don't know what the quantities are, but trying to do that from a food perspective, A, because I'm not the biggest fan of supplements, but B, just because of knowing how fragile polyunsaturated oils are, I would much prefer it to be in a food form if possible. And I've seen certain research around where they test a whole load of supplements, and even the ones that are meant to be the highest standard of care, etc., turn out to be rancid or have impurities, etc. So I just wanted to get your thoughts on that.
Yeah, I know. That's why I don't like it either, because there's no way to really know. So the amount of DHA that a person with PCOS needs is about 500 to 1,000 milligrams a day. That's the amount that I recommend for them to supplement. So that's really hard to get through food. And I mean, a person can try, but that would be really hard. And so I think we need to just keep staying on what are the best ways to, I just want to keep knowing what kind of supplements would be the best to recommend. And so I only recommend people to use ones that are third-party tested, so they actually know they're getting the amount that's in there. And the rancid issue, I think, is something that I know for the last few years as dietitians, we've been talking about that. And, I feel like that's why it's important just to keep reading and trying to figure out which ones are going to be the best. And, it's there's always going to be some kind of thing that makes it imperfect, but so we just have to do the best we can with what we got. And sometimes people are like, well, I can get the Equate brand at Walmart for this really good price right now. Is it okay if I get it? I'm like, yes, it's okay if you get it. Let's just try that and see what happens. And if it, I don't know, I'm really flexible in that way. That to me is okay, if that's all you have, it's that or nothing, let's do it, So I think especially for the fish oil supplement or the omega-3, if someone does the vegan version, as long as it's labeled how much DHA is in there, then I'll be okay with them trying it. It is a risk though, if you don't know for sure if it is actually, has fish oil in there or if it's gone rancid, like you said.
Yeah. And so what about, there's just a couple of other areas I'm thinking of, sleep. How important is sleep in PCOS? What are your recommendations around that?
Yeah, sleep is definitely in one of those 12 steps. And I've seen estimations of 75% of people with PCOS have a sleep disorder. And so it's recommended on a regular basis to get a sleep study. I often tell my clients at least every 5 years get one. There are some people who say every other year, every third year, which is, I don't know, it kind of seems a lot, but they're easier to do now. I know people don't even have to go to a sleep study place anymore. They can just take it home and do the sleep study at their own house. But still, it's definitely something that's really important. And what we know with sleep is coordinated by circadian rhythms that are run by hormones. And so because hormones are involved, it can be involved with PCOS, especially the higher insulin levels get, because insulin is part of that kind of sequence. And so if someone has high circulating insulin, it's going to affect their sleep. And then having poor sleep is going to make insulin higher, which is going to, it's like this snowball effect. And when I talk to other people like sleep experts or people with PCOS, what I'm seeing more and more is people with PCOS need to protect their sleep as much as they can. My kids are older now, but as someone who at one point had infants, that's impossible to do when you have a baby who's not sleeping. Yeah. So do what you can. But I see some people say that people with PCOS need 9 hours of sleep a night instead of like 7 or 8 that we see for people without PCOS. They probably need 9. And that also like the screens and like blue lights, watching Netflix before bed on your laptop or something that may disrupt people with PCOS even more. And so trying to have good sleep hygiene, an hour or two before bed, not just like reading or doing something that doesn't involve a screen, can help with that process. But getting a sleep study for so many people I work with has been a huge impact, like a positive thing on their health by using, whether they just have a device that helps them breathe better. They're like, oh my gosh, I didn't know how tired I was because they're just tired for so long, and like, like the cravings change just from that, because insulin levels come down.
Yeah.
So yeah, sleep is definitely a big one. One that I haven't really talked that much about, I think I'm totally changing the subject, but it's something that I think is important, is, cause I talked a little bit about protein when we were talking about carbs, but the first like food thing that I often will talk to people about is not carbs. Like I said, it is protein. And it's, something I always say is that people with PCOS probably just need more protein. Like we don't know we don't know if everybody, but they probably do. And, so experimenting with that before taking anything away, just adding more protein to see if it does anything. For a lot of people, that's a big deal. Like that's something that has allowed them to feel just like they have some more like what they would call as normal amounts of energy. So yeah, I wanted to throw that in there before I forgot, but that's another thing that I often will, that's like in one of the first few steps too.
Okay. And I would agree with that for people even outside of PCOS. Like when I look through people's food logs and what they're eating, protein is probably one of the things that comes to mind first. And especially because if you're out and about, it's not as easy to come by. Like you can normally easily pick up some fruit. You can normally easily pick up a sandwich. You can to get protein typically takes a little bit more forethought. And so it just doesn't appear as much in what people are doing unless they've, gone down the paleo route.
Yeah.
But I think it does make a really big difference in terms of satiation, in terms of having sort of even energy for them, having energy go on for a longer amount of time. So yeah, I want to second that comment.
Cool.
And with the sleep side of things, with the sleep studies, is it just looking for sleep apnea or are there other sleep disorders that get picked up on? Because I've had clients like you have who did a sleep study, got diagnosed with sleep apnea, and now using a CPAP machine and have noticed how much of a benefit it is for them having more energy, changing their food cravings, etc. But I just want to know, is there other disorders?
There are other disorders for sure, because sleep apnea is not the only one. There seems to be different types. I'm definitely not a sleep expert, but there are other ones besides sleep apnea that are found with PCOS. Sleep is really complex, It's a really awesome thing too, but it's a complex experience. And so, yeah, there's other ones. And so sometimes people will say, well, I know I don't have sleep apnea, but it's still good to get the sleep study done because there could be another one that you're experiencing.
Okay, cool. And then what about stress? And I know stress is a very general big word, but how do you think about stress and PCOS, and what are some of the things that people can be doing to mitigate that or deal with it?
I think it's important for people with PCOS to consider what the stress they can control and what they can't. And I say it like that because there's some stress we just can't control, and it's important to just name it as a stress. Oh, I'm oppressed because of my size. It's important to name it. Again, that kind of comes from a feminist approach of naming something. So then it does bring down some of the stress level, but it also is it's not your fault. So, but it's still there, and it's important to give yourself space and rest. One of my favorite Instagram accounts on the planet is called the Nap Ministry. I don't know if you've ever seen it, but
I have not.
It is amazing. It talks a lot about people who are marginalized or oppressed, how in order to fight things like white supremacy and the patriarch, they need to rest. There needs to be less of the hustle culture. There needs to be less of the grind and more rest. And I feel like that's how PCOS can be a part of that for so many people. Like many people with PCOS are living in marginalized bodies in many different ways. And so making sure that they are like naming how they are being stressed in their life and then allowing themselves as much rest as they can. And then for the other types of stress, the things that probably are more conventionally talked about and maybe like wellness culture and things like that, there's certainly research on yoga and meditation as it relates to helping with stress levels and having a chronic pro-inflammatory state that we see with PCOS, finding ways to help just calm the body however you can in any way you can is certainly something that will be able to help metabolically. But again, it's like there's only so much you can control in that way. But if you're able to set up space in your day to be able to do something that's stress relieving, that is something that certainly is going to help the management of it. And I will say too, people talk a lot about exercise with PCOS, but I also feel like meditation and rest, those are also a way of moving your body. It's resting your body. And so I often will talk about that with my clients. Okay, like how are you making sure when are you resting,
Yeah.
and to help replete, to help with the stress management.
And I know you mentioned meditation there. I've started using guided meditations with clients to help with digestive issues. I know there's some pretty decent research on how helpful that can be. And I saw as part of your course, you do meditations as well. And so what is it purely from a relaxation standpoint, or it's more also like changing beliefs, etc., as part of that content?
Yeah. So I use the meditations on my course to be in urgent times. So if a person's in a place where they really want to check their weight, or they're having a really intense craving, they're experiencing something that feels urgent, and then they feel paralyzed because of that. I use the meditations as almost like a guide to help them decide what they want to do next, so they can feel. My intention is I want them to feel at home in their body, so then they can inform their decision based on what they value and what they want to do. And so that's what those meditations are for. And I love using guided meditations for stress management for myself. And I encourage my clients to experiment with that. And I also appreciate, especially I do work with a number of people who have a trauma history. And so meditation and trauma history for many people just don't mix. It's just too threatening, or it's something that touches something that I think is important for them to not touch right now, And so, part of my trauma informed care also is like, hey, meditation is not going to work for everybody. And that's not a judgment. That's just how we're all different, and also our different lived experiences. But I love Insight Timer. That's the one that is my favorite. Guided imagery, or you could do ones that are just not guided imagery for meditation.
Okay. I haven't come across that, so I will put that one in the show notes. So, favorite. You touched on exercise or movement there. In terms of movement, do you find that to be beneficial for PCOS clients, or it depends on them and what they find useful?
Well, this is what I think about the movement piece with PCOS. To me, when a person comes into my office, or if I'm having, we do monthly Q&A calls with our course, whenever someone's like, Julie, I'm having this weird experience where I'm craving movement. It's not like I feel pressure to do it, but I'm craving it. Like I want to move my body, but I don't know what to do. That is something that I hear really often. And it's a clinical sign to me that this person is probably eating an amount that their body needs to feel like at least sustainable. I don't want to say enough, but it's probably close, if not enough. And their insulin levels are coming down. So they have found some tools that are working for them. And so they're feeling in their body, and their body's craving some movement. So let's figure out what they want. And so to me, it's a really wonderful marker to know. That's when I take lots of notes. Okay. I'm like, okay, they started an inositol last month. They are eating protein here. I'm like, okay, I need to document this for them so they know which tools are working and for them. And from there, the movement piece, it's really important to make sure that a person with PCOS, if they are choosing to move their body an amount that's more than like 20 or 40 minutes, if they're going to be like maybe training for a marathon or something like that, that they need to know that they need to make sure they eat enough, because it can make that imbalance again where it's stressing the body out. And so, some people with PCOS are like, well, I have to exercise for 2 hours a day or whatever. I'm like, actually, that would be not a good thing, in my opinion. Like, let's make sure you're eating enough to support that. But do you actually like working out that long? And certainly I've had some people with PCOS that I worked with who are amazing marathon runners. And, that's great. But you just have to make sure you eat enough. But when it comes down to it, the recommendations for PCOS are not much different than the rest of us. Yeah. It's like, do what your body, what feels good in your body, and having some variety may be helpful. Maybe some that require strength, some that require more endurance, but having kind of the variety seems to be the most supported in research. But it's really that 20-minute to 40-minute mark that seems to do something with the insulin piece to help manage blood sugar and insulin levels. And so it doesn't necessarily need to be that long. And when I say need, I have to just make sure I reference like a person with PCOS, exercising may be the worst thing for them and where they are right now if their body's insulin levels are really high and or they're not eating enough. So don't force it. Like if you're feeling like I don't want to move my body, I'm like, that's a great clinical sign. Trust it. There's something there to that. You can trust it. Let's figure out what you need. And then when you start to crave movement, that's when I would encourage you to explore what you want to do.
Yeah, definitely. And I mean, the two things I would add to that is one, like, people need to rethink about how they think about exercise, which is often why I call it movement. Because if you're feeling not great and you're like, oh, exercise means going to a boot camp, you're going to be like, no, I can't do that. But if it was framed in the exercise means going for a walk for 20 minutes, someone like, oh, actually, I could do that. I didn't think that was exercise, or I wouldn't think that would even be useful because I'm not going to be, dripping in sweat or whatever it may be. So I think there's that. And then there's the other one of like, okay, what sounds like fun to you, even if you don't think of it as this is going to make me lose weight or this is going to add to my health or anything like that. Like, what would you do if you found out that it was doing nothing for you?
I think you're speaking to so much that are important, because so many people with PCOS have been pushed to weight suppress or like to focus on weight loss. And so exercise has been this punishment. And so, I have to be doing it for so long. I have to be sweating. And so there's ends up being this really like rigid way of experiencing it because they're just doing what they're told. And that's awful. And another thing that's really important with PCOS to keep in mind is, most people with PCOS have high circulating testosterone or some androgen level that's higher. And so a lot of times people with PCOS are pretty good at sports. Like they're able to add strength pretty quickly. They're pretty good athletes. Not everyone would say that, but so many of my clients with PCOS are like, yes, I was really good at soccer in high school. Like I should have played ball in college, but I thought I was too fat to do it then. Like there's something that kind of got people away from it. And so that's really cool to see when people then start to fuel their body enough and figure out tools to help manage the condition when they get back to movement or sports or whatever they really liked. And they're like, oh my gosh, I'm still good at it. Like, this is awesome. So I don't know. I think that's a really cool part of it. And there's not many perks to having PCOS, but for some people, that's like, I guess, like one of them, is like they may actually be stronger than other people who are assigned female at birth. It's kind of just neat. So
yeah, definitely. I mean, the other one I would add with this as well is when people aren't really up for doing exercise or movement to any degree, the encouragement I always suggest is see if you can still get outside time, because I think a lot of the benefits of exercise come down to you're getting more sunshine, you're getting more fresh air. So even if it's like walk 20 meters and sit on a bench so that you're getting good amounts of sunshine during the daytime, because I mean if it's connected to circadian rhythm issues, it's connected to sleep issues, that's going to really help from that perspective.
Yeah, totally agree.
So the final thing I just wanted to ask about, I know as part of one of your courses, I think it's like the practitioner course, like you talk about like a PCOS intuitive eating scale. So I don't know how much detail this goes into. Are you able to explain that?
Yeah, I would love to. Yeah, that's something that I developed with Kimmy Singh a couple years ago. I sat down with her and I was like, okay, this is what my clients with PCOS have been telling me. And this is kind of what I'm picturing in my brain, like using the intuitive eating scale. I believe and know that people with PCOS can do intuitive eating work too. And I really feel like there was this myth that people with PCOS couldn't do intuitive eating work because of the cravings and all that. But I'm like, no. They can work. And so we had this big whiteboard and we just were drawing it all out. And, since Kimmy experiences PCOS, she was able to kind of give me her lived experience. You know, it's such a wonderful gift to be able to have her to help me do this. And so, yeah, like using the intuitive eating scale, we basically we designed this top and bottom difference. And the bottom of the intuitive eating scale for PCOS is when someone is having their PCOS is not being managed well, whether it's because they're not given enough tools or they're living in poverty or they're being pressured to lose weight or something like this, or maybe all of those. And so there's constant cravings, there's lots of fatigue. And we kind of were thinking of it almost like when you're in a city and there's like horns honking everywhere and lots of noise and smog, and it's hard to like hear your own thoughts, you know, it's just really clouded. And but yeah, you can still your body's still giving you information. But then the top part of the scale, if you can kind of picture that, there's still some kind of noise. There's just not as much. And so the way that a person physically experiences hunger and fullness still has some predictability, but it's still a little bit different than people without PCOS. And that's what the scale kind of goes into, is like, what are those different physical sensations that people have with hunger and fullness when PCOS is managed well. And then again, on the bottom, like when it's not in a way that's working for them. And, you know, it's been really neat what people have been giving me feedback on with it is that it just feels like they're getting validation that like, okay, you just weren't given the tools. And it's been helpful just for them to learn new words to describe their own hunger and fullness, you know? Yeah. So, and it's definitely like in its beta stage, I guess you could say, you know, it's still early on, but yeah. So if you're listening and you experience PCOS and you're like, oh, I can't like listen to my body or eat when I'm hungry, stop when I'm full, something always to keep in mind is intuitive eating it's 10 principles, not 2. You know, it's not just hunger and fullness. It's lots of other things too. And, you know, your body has different cues to let you know when it needs something. And as a clinician, I feel like my job is to help you to sort through what those cues are. So then you can file them away to know what they mean, you know, and this kind of intuitive eating scale is right now kind of like a stamp of a lot of that collection over time.
Cool. I mean, it sounds like it's not just for PCOS. Like that sounds like it could be very useful for people in lots of different conditions where it just makes things a little foggier or difficult for them to discern. I mean, one of the things I will often do with clients when we're looking at that hunger and fullness piece is to send them a list of all the different symptoms that could be pointing towards the fact that you're needing to eat. And there's a couple that are like the obvious, you've got a growling stomach or something that they're going to connect very much with their digestive system. But the vast majority have got nothing to do with that. It could be cold hands and feet. It could be feeling a little dizzy. It could be change in terms of your vision. It could be irritability, etc. And so clients will read through that and then start to pay attention to their experience. And what they typically notice is the point at which they're getting a growly stomach was like an hour after when they should have eaten. There's so many other clues that are earlier than that point. And that's often what I'm helping people with.
Yeah, I totally agree. Because there's, especially if someone has been used to dieting their whole life and or experienced an eating disorder, the hunger, fullness, and just intuitive eating work will look different until the body has nutritionally rehabilitated to a certain point, you know, and then it becomes more what we would imagine.
Yeah. Definitely. Well, look, Julie, this has been amazing. We have covered a lot. Is there anything I haven't asked you that you really wanted to go through?
No, I feel like this has been a wonderful overview of PCOS. It's really great to chat with you and get to know you. And I'm glad that I was able to share this information with your listeners. So thank you.
Perfect. Well, look, tell people where they can go to find out more. I know we've made reference to your podcast and to your courses, but yeah, just tell people what is available from you.
So the easiest thing is just go to my website. Everything's on there. So it's Julie Duffy or rd.com. Oh my gosh, I didn't almost say my website right. Julie Duffy rd.com. And from there, yeah, if you look on my services page, you can link to any of the courses I sell or working individually, or there's also a link for my podcast. You can connect with it there too.
Perfect. Well, yeah, thank you again. This has been awesome. And I know people are going to get so much out of this because, yeah, I haven't really touched PCOS before, and we've definitely touched it today.
Awesome. Thank you. I enjoyed our conversation very much.
Thanks for listening to Real Health Radio. If you are interested in more details, you can find them at the 7 Health website. That's www.7health.com.